Hello, everyone. Welcome back to Smart Medicine Episode 2, where we explore how physics, AI, and clinical innovation are transforming healthcare. I'm Dr. Ali Fatemi. I'm a clinical medical physicist, entrepreneur, and a founder of Spentex. Today, I have a privilege joined by one of the most influential figures in our field. Very good friend of mine, collaborator, and my mentor, Dr. Daniel Lowe. Dr. Lowe is a professor and vice chair of medical physics research and innovation at UCLA. Dan's work has defined multiple areas of modern radiation therapy, from the early stage of IMRT that kick-started his career to the motion management, image guidance, MR-guided radiation therapy, and now is model-based CT simulations through his company Respirati. Dan published more than 310 peer-reviewed papers. He holds the board certification from ABMP, a fellow of Astro, AAPM, and has the most cited paper in the history of the Journal of Medical Physics, which is with more than 30,000 citations, with the Google Scholar with the H factor of 78. Dan, it's truly an honor to have you here with me.
Thank you, Ali, for those nice accolades. It's my pleasure to be part of your podcast.
Thank you. So, Dan, we just want to jump right into the questions. I think this is something that I really enjoy to know about your opinion, your vision always. You were at the very start of IMRT, the period that transformed the way we think about the precision and radiation therapy. In many ways, probably that shaped your career during time. Can you take us back to the time? What was happening in the field? What was convinced you that was a direction that radiation therapy needed to go?
Well, I started in 1988 as a postdoc at MD Anderson, and later joined WashU as a faculty member. 3D conformal radiation therapy was just getting started. Radiation therapy was going from 2D, which is you're using mostly prescribed radiation beams that might be defined by the specific kind of tumor and the extent of that tumor from a very crude way, to a patient-specific three-dimensional dose geometries that were generated using images and imaging. So a lot of concepts were developed to manage this, including concepts of tumor and target volumes, dose volume histograms, other things that allowed us to quantitatively evaluate how the radiation was going to be delivered and what its consequences were going to be. Now, at the time, we thought this was the be-all and end-all. We'd gone from this very crude approach to 3D and patient-specific, and we really thought that the rest of medical physics was just details, that there wasn't going to be much left to study. And then independently, Brock Mackey and Mark Carroll realized if they could invert like this math of a CT scanner, they could create radiation dose distributions by computer optimizations on a novel delivery method. So they built tomotherapy and nomos respectively. The first time I heard about IMRT, which is what is called intensity modulated radiation therapy, right? This idea that your computer can decide for you what the radiation beam should look like, and they get delivered by a complicated, basically a robotic machine. Mark Carroll had shown a radiation distribution at Astro, which is one of our main organizations, at their annual conference, of a smiley face on a piece of film. So the film would show in dark
I know
what
that.
the solution was. And I thought, this is ridiculous. Who cares? Who needs a smiley face? So I totally didn't get it, right? I totally didn't get it. I figured it out soon. And that really was like the initial push to get me going and try to figure out how do you make sure it's safe and how do you make sure it's accurate, et cetera.
Now, when you look back at evolution from IMRT, image-guided therapy, and now adaptive radiation therapy, what do you think is most important shift that make this transition happening in clinic?
And there's no question that the main issue is commercialization, right? So
Right.
IMRT, for example, had many scientific papers by Anders Brahmi and others developing the theoretical framework that this could be done, but it wasn't until it became a commercial reality that it actually made it into a clinic and would impact the clinic.
It's interesting that you just mentioned about the clinic. How we can bring this into the clinic? What is the problem?
Well, if you're talking about specifically about adaptive radiation therapy, there's actually quite a few paradigms that have to get changed, right? So one of the things is that as a medicine, radiation oncology is fairly attractive because it sort of, in a sense, decouples the delivery of the medicine from a schedule like surgery, for example. So surgeons, they have to be there at the surgery with the patient in the operating room where nothing gets done, right? And in radiation oncology, kind of like radiology, but in radiation oncology, the physician meets the patient, but almost all the work as well as the delivery are done separately and in parallel to their work. So they don't have to be at a specific place at a specific time for the most part. That's actually not true. Even now, we have workflows that some physician has to cover, but they don't all have to be there if their patients are being treated. Now, adaptive radiation therapy, almost by definition, takes the treatment planning process and crams it down to a few minutes. You have the old plan, you have a new patient anatomy, which was imaged, you have to get contours, which are segmentation, you have to have a new plan, and then someone has to review that and approve that in a very tight time frame. And so a physician has to be available at that time, maybe not at that place. Early adaptive radiotherapy systems required you to be physically there, but now remote access is much easier. So maybe it's just at the right time, but not necessarily the right place. That's a change in practice. Second change in practice is that therapists, the people that treat the patients, they are now often involved in the planning process because they're sitting there with the data right in front of them and they're already there. In other words, they're a resource that is physically present during the treatment, and anyone else has to be brought in, has to be coordinated, and et cetera, has to be available. And so a lot of places the therapist is some of the therapists are changing their roles, becoming more like combination therapists and dosimetrists or therapists and planners. Um, that's also a fairly big hurdle to overcome. So it's physicians, in part it's therapists. Also, the equipment isn't really quite there, and the software isn't really quite there.
So we have to talk about new technologies, right? What do you think about the role of AI, future AGI, or automation changes to the adaptive radiotherapy in the next 5 years?
Yeah, so you see a massive range in predictions for AI going from kind of worthless to ends the world, right? And nobody really knows where in this domain is. Okay, so what limited experience I have with AI, both academically and personally, right? Um, it's unclear to me how there could be even a relatively short term, a highly robust AI-driven workflow that still doesn't involve significant amount of manual and personal effort. So for the foreseeable future, AI will definitely save time, and that'll get better and better. In other words, the time it takes for people to do the specific jobs will get less because it's doing a lot of it. But since it doesn't do it very well, since it doesn't do it 100% reliably or even 99 point whatever percent reliably, humans will still be involved, especially since there's a lot of mistakes that can be hidden, that there's just simply not enough time and bandwidth during the adaptive session to double check. So better to have things that are done either by humans or focusing on humans than just giving it all to a computer, and then you got to double check all of that and fix what there is. But I think that with the status of AI that I understand now and the relatively limited data that's available to AI training for medical applications, especially our applications where there are tumors, it's unlikely that AI will do much more than save time at best over the next, say, 5 years. That doesn't mean ultimately it won't kind of take over and do everything, but it's going to be a while. It's going to be a while.
I want to talk about innovation, translation, and the 5D CT. You know, I have seen it, you have seen it. There's many technologies that they really promise in research, but they're really struggling when they make them into the clinic. What do you think is really takes to translate an innovation into the clinic?
Again, commercialization is 100%. That's really true in everything we do, because AAPM also does guidelines and standards, like the concept of the GTV. What are these margins that we use to address uncertainties in the tumor's position? Yeah, I don't want to use too much jargon, right? Those weren't developed by a company, and they're used worldwide. So there is plenty that can impact the clinic that can be provided by experts or organizations or what have you. Okay. So I don't want to make little of that. When you're talking about technologies that deliver or plan or do things that have maybe that are actually impact individual patients, like their actual treatment, it's unlikely that's going to be provided by those types of organizations. And that really ends up being much more of a corporation or a corporate driven product.
DCT. Please explain to me what is it, what problem you guys solve, how you are working out in order to bring it into the clinic. There are some limitations with 4D CT. The 5D CT, which is your model-based CT simulations, has more advantages. And I think also your company, Respirati, trying to bring this into the clinic, and their promise to improve the motion imaging and planning based on CT.
So let's go into really quickly what it's replacing. So 25 or so years ago, probably close to 30, no, 20 to 25 years ago, we were, remember, with this 3D thing was coming around, and we wanted to understand, how do you treat a lung tumor? Because it's moving due to breathing. So the vendors, the people that made scanners, took the cardiac algorithms, the algorithms for imaging the heart, and just applied them to breathing, so that we would image the breathing cycle. The problem with that is that, unlike the heart, the breathing cycle is not regular for pretty much anyone. Some are pretty regular, but most people, patients especially, cancer patients especially, it's not that regular. And so I was like, okay, there must be a way to fix this. And it took many years. And maybe somewhere around 6 or 7 years ago, I had sort of put all the pieces in place to replace 4D CT with what is generally called model CT, but our model is called 5D. So we call it 5D CT. Now, you remember you mentioned the cited paper? That paper was a technique which is actually has it's an equation, and it has a quantity called gamma, little lowercase gamma.
Gamma analysis.
And I had no idea. I just published it. I just threw it out there. And it happened to show up at a time when all these companies needed to be able to make clinics, and therefore companies needed to make devices that could measure radiation doses and provide feedback to the clinics of how close were the planned radiation doses to the delivered radiation doses. And that was kind of what gamma was for. And so it was just out there in public domain. And so they literally all picked it up. And the reason it's so highly cited is because every single commercial system that compares radiation doses, and frankly, many academic comparisons, use it as a measurement, as like a ruler. That's why it's that. So, if you build it, they will come kind of concept, right? So I thought, we'll do it again. If I publish everything about 5D CT, it's clearly better, it's clearly superior. Some vendor, Siemens or GE, or maybe even a therapy company, would say, hey, it's better. It's all in the public domain. Just do it. Let's do it. I couldn't be wronger. I couldn't be more wrong, for a whole bunch of reasons. First of all, there was an alternative. There was no alternative for gamma. So, and analysis is fairly low bar. You don't have to, it's not a medical device. Gamma is not a medical device. So more importantly, there was no alternative. And the entire world has been 4D CT for 20 plus years. So literally that's all there is on the planet, except at UCLA. So everyone's kind of used to it. It is what it is, what have you. But you also notice that it's really hard to nail down automation of the process from planning to delivery. And my argument is this: because 4D CT is unreliable and very sensitive to breathing irregularities, and it's not quantifiable. Okay. So our process is presumably that. So we started Respirati about a year ago to attempt to not convince, but to entice vendors to take it seriously and make it a commercial product. And it's myself, it's my colleague Drew Moganaki, who's a radiation oncologist at UCLA, and then Dharani Rangaraj, who was actually a physics resident at Washington University when I was there as a faculty, became a faculty, then went on, and now he's an entrepreneur. And so between the three of us, the idea is we can split up the attention and the expertise, and it's not me as an investigator just trying to knock on windows and doors to figure this out. So we have developing a concerted plan to move it forward. The hopes for Respirati are to ultimately convince a vendor to put in a DCT, at least try it, or develop some other model-based approach. There is some IP. When I realized that this published it and they will come wasn't working, I took some of these things we had not disclosed and I put them in UCLA, and we do have one patent. Hopefully we'll have one or two more. And so there is stuff to license that these vendors could license from UCLA through Respirati, but we'll see. We're just trying to get their attention and get them to take it seriously.
So in order for me to kind of summarize the whole thing, if I want to give this as advice to someone, like some physicist or some some startup, you have to start with the problem, solve the problem, and then make sure that it's validated in a clinic, and then find the right team, right, with the different expertise to bring it in order to be able to commercialize something successfully. I guess this is what I'm actually kind of think about the good recipe. Is there anything else you want to add into it?
I think you're right. I think that sounds like a good ingredient list. It's not a recipe, it's an ingredient list. And that's not the same, right? So probably the first and most important thing to take seriously or to absorb is the idea that your training and frankly your mindset, for most of us who are academic medical physicists or just medical physicists interested in innovation, et cetera, that we're not wired, most of us are not wired to be entrepreneurs or even to be CEOs of an established company. And we're all over the map in that, right? So really to get and trust expertise in the things of which you are either not wired for or you just simply don't know. And I've watched a number of founders of companies that were ultimately successful themselves be unsuccessful because they couldn't sort of work out the difference between an inventor and a person that is leading or as an integral part of an established enterprise, an established company. There are probably plenty of failures I never heard about because they never got anywhere. It's not even true. I know one, I won't bring it up who it is. I know one because the person that was the inventor just was not a business person and would trust no one with like the direction of the company or responsibility of the company, and the company foundered for 10 years and then just so it takes, I think, a lot of insight to understand who you are and what are your strengths, ultimately give up some responsibility, some of the financial gain to others. And, obviously that can also backfire. Obviously, you got to take a risk, but you got to do it on your own. It's going to fail, right?
I know exactly what you're talking about. The numbers of these founders we know, medical physicists, started and a good idea, even they commercialize it, but they're not very successful in the business part. They haven't finished the deal. Like some of these startup companies starting to develop these solutions, which is actually they're going to directly use in our clinic. These AI-based or automated-based solutions placing our job. What is going to be the role of medical physicists in the future? I believe medical physicists can be a clinical data scientist, but medical physicists has a deep knowledge of physics, medicine, innovation they can bring into the clinic. Are we going to lead, or are we going to have to react into this process?
Again, 20 years ago, no, more like 27 years ago, I was told in no uncertain terms that the end of medical physics was in sight. We would simply push buttons. There was no more development to do at all. As you know, IMRT, image guidance, adaptive radiotherapy, and now AI, and maybe flash, and maybe other things, some of which we know, some of which are going to come out of left field.
Yes.
So I've actually thought a lot about this. Why is it that we can't just push a button in this era and walk away and the patient gets treated and then they leave? You look at factories. Look at factories. I mean, they're unbelievably automated. Robots everywhere. And two reasons. One is every patient is different. Okay, that's pretty obvious, but okay. Two is there's never been any stability in our field. It takes a very long time for a company to do anything, especially a large company, that is an FDA cleared product to make a change, an improvement or whatever. And so that investment has to be worth something. So imagine they're going to invest in an automated system and they're not stupid. They know in 4 years, the entire thing's going to change. They're not going to do that. So the fact that there is a heterogeneity of options out there, almost every clinic is different than every other clinic in a number of ways that are very hard to change because the physician's in charge and they want it the way they were trained and they want to do it the way they were trained. And there has been fundamental changes of technology have allowed our field of medical physics to, and academic as well as clinical medical physics, to flourish and actually grow substantially over those 25 years. Because the danger and hazard of radiation therapy are not going away. You're always treating people with an absolute amount of radiation that if it's in the wrong place or slightly too much or too little will kill somebody. And that's pretty uncommon for that kind of thing, right? As a medicine anyway. And there's a lack of stability. Now, you asked about today, right? Well, today AI is one of those areas of instability. That this idea that models are going to come in, they're going to change how we work and operate. Absolutely true. We will have to change. We will have to add expertise that we don't have now, we being the general medical physics. But guess what? Imaging had to get added, right? QA of individual treatment plans had to be developed and added. In 25 years, we added a lot of stuff that was not in the playbook 25 years ago, period. In fact, I've had a discussion with our resident director that 2 years, which was defined at WashU, by the way, right? WashU, the first accredited residency in the country. And Sasha Mudik, I think, was the first resident of this, right? Right? Okay. That is the same 2 years, but it's not the same information. And so this idea that there's going to be a replacement or a lack of need for medical physicists, at least for probably at least 10 years, is really unfounded. And remember, it's a garbage in, garbage out problem. You don't get AI without data, and data is not the data that they have access to is highly limited and highly heterogeneous, and patients are very different from each other. So I think that it will help automate some processes. I think it will help, but it's going to be a slow go of it, right? A slow process, right? And I can almost guarantee you, which I won't do because prognosticate my strong force, whatever is that something else will come up and disrupt within 5 or so years. Maybe it's Flash. Flash would definitely disrupt things and change everything, and massive amount of changes would have to happen. But even if it doesn't work or work out, other things will.
You mentor many people in the field. Most of them are leader in the field. You just talked about Sasha. What is your advice for early career physicists? What's how they can navigate the tension between research, clinic, and innovation?
Okay, so I'm a data point of one. Okay, so um, I a long time ago, I got very lucky that I married the wife I married. Still my wife, right? 35 years, right? 35 years later, right? So I had an opportunity. I met her in February and we got married in December and moved in January. Okay. So she's a lawyer and she was about to make partner in practice in Houston. And we moved to St. Louis where she had no job. So I could start a junior position in St. Louis. So a couple things. One was I was lucky enough that she would let me do that, or we did that, right? Um, Number two, I realized that the most important thing for my career, which was definitely going to be an academic tenure track career, that my career was going to need the best place to flourish, and that would be a solid academic institution that really believed in the balance of clinical work, teaching, academic productivity, and service. I didn't really know those 4 terms at the time, but I kind of got it, kind of, sort of, right? And WashU seemed, and it was an outstanding example of that. So number one, did I want to live in St. Louis? Not particularly. I lived in Bloomington for 7 years. I grew up in LA. I'd already been with the heat, the humidity, the cold of the Midwest. Wasn't like, but it didn't matter, right? Mattered to me was what did I do during most of my time, which is at work. The second thing was I was pretty comfortable, as was my wife, of me just becoming sort of um engrossed in my work. And my work was 2 components. One was the routine clinical work. And I liked it, but honestly, I liked it as a distraction. I don't know. I distract all the time. I loved it as a distraction. I liked doing it. I did it really well. Back then it was pencil and paper and a literally calculated. That was the complexity of most of the clinical work, right? So you could get it done pretty quickly, pretty efficiently. I liked helping. I solved problems that could have hurt or killed patients all the time. I had a great, I mean, I really, really enjoyed that part of it. But to me, that wasn't what got me up early and just kept me going. And what that was the academic side of like, what can we do? What we can discover? And I got lucky enough that we were one of the early Peacock systems, which was one of the earliest tomotherapy machines available, IMRT machines available. And so I was doing hundreds and hundreds of film measurements. That's the only system we had, which was radiography. You got to process it, blah, blah, blah. And we used to have a joke with Sasha that if we hadn't been there for 12 hours, it wasn't worth coming to work. Now, I can see that. I can understand some people would be like disgusted by that. But if your work is if your work is your vocation is also your avocation is also your hobby, like you just want to keep doing it, there's literally nothing wrong with it. It's a phenomenal blessing to be in the situation where you get to do that. Yeah, so it's not like there's a lot of busy work. There's committees and emails and paper reviews and a bunch of other stuff that comes across, right? That you have to do that becomes part of the busy work of, changes made from clinical to other things, but there's always a lot of busy work. I do use it kind of as a distraction because you can only focus on things for so long. I go back and forth, back and forth. But I think that if somebody really wants to be out there and wondering and exploring and figuring stuff out, it's a great place to be. And if that's you, then I think you'll also be driven by getting it done and just enjoying it. And it's great to have a supportive spouse who, in my case, has their own career. It doesn't have to be that, right? Same there, right? Doesn't have to be somebody that's like, yeah, I mean, she used to call me and like at 6 o'clock, go, so are you coming? I'm like, yeah, I'm coming. She called me at 7. I'm like, you coming? I'm like, yeah, I'm coming. And sometimes it was literally like midnight. And she didn't give me a hard time. She didn't give me a hard time. Even when we had our daughter, you know, she let it slide because I don't know why. I mean, I guess I should ask her, right? But she was highly supportive. So having a supportive environment is very important. And it's not like I don't have a lot of friends and colleagues who don't live that way. They don't get obsessed by the intellectual exercise of figuring stuff out. But I do. And it's a great place to do it. It's a great field.
Exactly. We
Yeah.
do every day. We walk into clinic. We have to solve the problems. You need to have a passion. You have a support from your family, friends. You have to be curious about this stuff.
If you want to discover things and not most people don't want, I mean, most of my grad students, honestly, that's not their career. Their career is more mainline. They'll do some academic work in a clinic. They'll teach a little bit. They'll do this, but they may not like be there all day just because they want to get the next thing done. It's just if you are like that, it's a great field to be in because we're paid mostly by hard money, right? There's a lot of clinical work to do, and nowadays there's much more than there used to be. So I don't want to belittle the amount of clinical load. I don't want to belittle it at all. But there's also great opportunity because there's huge numbers of, I mean, maybe it's like kid in a candy store, right? You have imaging and this and that, and there's a huge number of things you can investigate and delve into and tools that you have at these places that didn't exist before, right?
Do we need to change our training, like say graduate school or our residency programs to kind of training people to be more hands-on? What do you think? Is there anything we have to add? Is there any modification to our residency programs?
Well, let's separate graduate students and residents. Medicine it's a trade. There's a science behind medicine, but the application of medicine is a trade. It's a very technical trade. It's a very high stress trade. Requires a huge amount of knowledge and skill. I don't want to belittle it, right? It's not plumbing. Don't get me wrong, but there's a lot more judgment than most trades because there's a lot of gray in medicine. But I'm just distinguishing the practice of medicine from a science. That's all I really mean. Okay. The residency's job is the training of the trade. How do you do the things that have to get done in a clinic? While in principle, the graduate studies are learning how to do science. Now, we do research as the residents do research, et cetera, but the job is not that. The job is to teach the trade so that they understand what and why they're doing from a clinical basis when they're done. As I mentioned, we added a lot since the 2 years was invented. So I think one of the things I've found that I'm going to delve into more because I just realized this shortly ago, so it may be inaccurate, so don't comment, right? Is I think that the material we provide to the the residents needs to be better organized and easier to digest because they have so much to do and learn that they shouldn't be spending, like back 20 years ago, you could spend time digging around a bunch of task reports and highlighting and writing things down and copying tables. I get that. And that's a lot of the trainers, have that like, well, you should just go read the task report. I mean, because that's what we did. You should do that. But they had a quarter to learn of what they have to learn now. And even the routine clinical work is much harder, cutting and pasting different systems, different rules that change constantly in the clinic. Constantly. Workflows change constantly because frankly, this software is pretty, I mean, it also hasn't stabilized. So these companies have been able to make a consistent set of software. Okay. So I think that one may be having a more straightforward, digestible set of educational materials for the practice of medical physics, and that digests and simplifies the presentation of all of these task groups and whatever, right? And I think that maybe some of the practice guidelines might be good places to start, and maybe it's sufficient, right? I honestly haven't really gone through them, but again, this just came up. The other one is we're going to have to add AI to some extent. Um, uh, learning on the job isn't a very efficient or effective way of doing it, and it's just life, right? And the job of us as residencies is to make sure they learn in a learning environment as much as they can in 2 years so that we minimize what they have to learn on the job. And ultimately we are responsible for basically all the software that impacts our treatment plans. Whether we like it or not, that's our role, at least in the modern era, right? And that includes auto this and auto that and auto this and auto that. So I think that at least understanding and either developing or following the advice and procedures and protocols of AAPM, Astro, whomever, is going to be really important. And so at least understanding basics of AI and eventually how AI is quality control and how it's going to impact your clinic are really important. And the problem is there's going to be a gap between the advice that's provided by, like when IMRT, there was a huge gap in time, years between IMRT is available commercially and it's in your clinic now, and when you go read something about it, and that gap is now. And how do we prepare our residents like during that era, et cetera? Those two things I think are sort of come to mind.
What is excites you about the next decade of radiation therapy or imaging or medical physics?
Primarily selfish, and think that we're going to get out of the dark ages of breathing motion management. Okay, so number one, if you can stop the breathing, just stop it. That's the most obvious thing. If you can stop it the same way multiple times, it's not an issue. So with MR guided radiotherapy, you're imaging the tumor in real time. Presumably, these machines can gate. You can watch it. You can turn the beam on when it's supposed to be where it is, and it gets turned off when the patient got to breathe eventually. None of these machines are fast enough yet to treat in one breath hold, and you just do that over and over again. So barring some error in positioning of, in registration of the MRI, which could happen, right? It could be you're seeing it here, but it's really over there. Barring anything like that, is I think by far the best way to deal with. Just stop the motion, or at least image it in real time. Right? There are plenty of patients that can't hold their breath or can't understand what you're asking them to do, and so I think there'll be rules for free breathing treatments, etc. And what I envision is really a workflow that's simple and for the user, and quantitative, and goes all the way through from simulation to treatment delivery and gating or tracking in a way that's robust and accurate and consistent for most patients. There are patients that just can't sit still, that they're just fighting to breathe to stay alive. I don't know that we can do much for them. Luckily, for the most part, they're a minority. We have a lot of data, and they're a minority. They're a few percent at best. So the rest of them, even regular breathers, we can do, I think, a much better job, and we can make it easier for everybody. The amount of anxiety you hear from physicists when they're asked about what do they do in the treatment machine and how do they handle breathing, they don't really know that's all working unless you have V-Ray or Lectus, right? They just don't know. And I just think that this is, to me, and this is why I'm excited, right? This is why I do this all the time, because I think this is possible.
Yes. For me, it's two things. It's flash and MR guided radiation therapy. I mean, I think these two technologies is really changing our practice.
Let me just put so I don't want to belittle flash. I mentioned it, right? And no, but because it's still an unknown, right? It's still a big unknown. In order for Flash to be successful, a lot of things have to change, which would be extremely exciting for our field, for engineering, for vendors, for everybody, right? It's like reinventing radiotherapy. Right? It really is fantastic. I think that's absolutely no question. And I would have argued MR guidance, and I did for many years. And V-Ray is now back as V-Ray systems, which is very exciting. But the whole MR guided thing is still like on the edge of what do you want to call it? Against vis-a-vis the number of patients that have access to it. I agree with you. I think if the world was a better place, we would be shifting very rapidly towards MR guided radiotherapy.
Obviously, this is one of the concepts that me and you kind of working on it. That we basically says that okay, even though some people cannot access to the MR Linac, maybe we can bring in MR images into a clinic, and then using MR images for planning for radiation therapy is one of the essential things. Even we can use and get benefit of the MR soft contrast and functionality of MR. Dan, when you heard about smart medicine, the podcast name is Smart Medicine. What do you think about it?
Right. Well, I don't want to contrast it against dumb medicine. That's not really a thing. So it's indicative of kind of a reflective, careful, and educated or quantitative approach to medicine. I mean, I guess can I parallelize it? Can I make it parallel to smart homes? Maybe not. No, I'm just wondering if it makes sense, right? So, I mean, smart homes are things that are automated.
Do we think we go developing all these technologies? There, motion management, maybe we have a better treatment, more precise treatment. Maybe we have better techniques, better machines. Is that going to be contributed into smarter healthcare, smarter medicine?
I think that we can certainly argue that smart medicine is more patient optimized. It's just specific patient, whether it's their biology or their anatomy or their disease state or what have you, right? So working through the patient through the information that we can get from that patient, and then therefore model that use that patient's specific biology, whatever, right, to provide an optimal healthcare or optimal prescription for their healthcare, which may include chemotherapy or radiotherapy, what have you, right? There are huge numbers of challenges to that, not least of which are things need to be able to be reimbursed. There has to be money that can be made by companies, any company, right? Or it's just not going to, not that it won't happen, but that it's much harder to get implemented, at least broadly. It's, humans are complicated devices. And while we know the level of complexity, we don't know the solutions often, and it takes a long time to learn them because you can't just go take a bunch and try, right? You have to learn like on the job, right? You have to learn doing, and the thing you're doing is it can't be hyper or experimental, right? It has to be rational for that patient, and so a lot of it moves very slowly, rightly so, right? Moves very slowly, rightly so, and so I think part of smart is making that continue to happen in a way that moves us forward, and does so in a way that is partly aggressive and partly safe. It tries to balance those two things, right?
Dan, this is an amazing conversation. Thanks for sharing your vision, your contribution to our field. For everyone listening to this podcast, I think all of these changes and progress we have in medicine is not always coming from technology. It's coming from people who's actually bringing innovation into the clinic. Again, I'm Dr. Ali Fatemi. This is Smart Medicine, and stay tuned for more conversation. Thank you so much, Dan.